Kimberly. I'm one of the ID registrars. And the topic I've got today is cellulitis. So I know it's maybe not the most juicy of topics, but it's something that's really important and something which all of us come across day to day in the hospital as well as in ED. So just a couple of acknowledgements. Spiros Miakis, our head of department, and also Kate Wagner, who was one of our previous ICU ID regs, have provided a couple of the slides in this, so thanks to them. So we're just going to go through cellulitis management in a nutshell, and I'm going to try and pair it with some case examples to make it a bit more relatable. We'll go through a few of the special cases, which I wouldn't expect at RMO level anyone to know any details about, but it's nice to be aware of, and those are the sorts of things where you'd probably be getting ID involved. And then just a quick summary at the end with some key learning points. So jump in if you want to interrupt, that's fine, or we can do some questions at the end or at the end of each case. So skin and soft tissue infection. I've got a little diagram to remind everyone of the structure of the skin, our biggest organ. So the first few things, the impetigo, furuncles, carbuncles, those sorts of things, they're much more in the domain of GP land and outpatients. So I'm not going to go into them in a lot of detail, but there's a couple of slides at the end which I think you'll have access to if you want to do a bit of further reading. So predominantly we're going to be focusing on cellulitis and a bit on necrotizing fasciitis, which obviously is very dangerous. So incidence of cellulitis, about 200 cases per 100,000 patient years. That's probably a bit of an underestimate, and I think it does very much depend on what you're defining as cellulitis versus erysipelas. You'll find different sort of nomenclature in the literature, but there is a difference in terms of the layers of the skin involved and also the epidemiology. So cellulitis more commonly seen in our middle-aged and older population, and I'll talk about the risk factors, versus erysipelas, which is more superficial and more seen in the younger children or elderly. So risk factors for cellulitis, I'm sure you guys know all of this, but there's a lot of risk factors. So pretty much anything that disrupts your skin barrier puts you at risk of infection, and that includes things like ulcers, bites, injecting drug use, anything that causes inflammation of the skin, so most of the dermatological conditions, but commonly eczema, radiotherapy as well, so burns from radiotherapy, edema of any kind, so either from impaired lymphatics, and that can be either secondary from surgery to remove lymph nodes or from vein harvesting, or it can be a primary lymphedema, sort of to do with, it can be congenital, or from venous insufficiency as well. And the picture there is of one of the most common risk factors, which is toe web intertrigo or fungal infection, essentially tinea pedis. And it's something that you'll find every ID registrar checking for, but you won't find many other people checking for, and it's a really important risk factor. And if you look closely enough, most people with cellulitis will have this and won't know that they have it.
Anything else causing it?
It's a portal of infection, so it causes skin cracks. So it's one of the most common reasons why they'd be at risk. Any form of pre-existing skin infection also puts them at risk, so for superinfections such as varicella. And other more sort of general risk factors, obesity, immunosuppression of all kinds, but even mild immunosuppression that you would see in someone with uncontrolled or poorly controlled diabetes. And MRSA carriage or contact with colonized individuals is a more specific risk factor for an MRSA infection or staphylococcal infection. So case one, so 73-year-old lady, this is something we see every day, comes to ED, referred by her GP, increased swelling and discomfort, increasing erythema over a couple of weeks, and the GP started her on Keflex. She's been on that for 4 days, no real improvement, and she's got a host of comorbidities, most namely diabetes and obesity. So what does she have?
Venous insufficiency.
Yes, good. You didn't fall into the trap because you guys are RMOs. So chronic venous insufficiency is what this lady has, otherwise known as acute lipodermatosclerosis, which can be a sort of complicating feature of chronic venous insufficiency and can look very much like cellulitis, but it's bilateral, and bilateral cellulitis does not exist most of the time. But it would be really uncommon to get a simultaneous infection of both legs at exactly the same time, flaring at the same time with risk factors on both sides. So if I had a cent for every call I get about bilateral cellulitis, I'd be a very rich lady and probably wouldn't be here. But don't fall into that trap. And we've already sort of mentioned this, but erysipelas and cellulitis, they're more classical terms. You won't hear many people referring to erysipelas anymore. People just group it all together as cellulitis. And for all intents and purposes, that's probably fine because both of them are caused predominantly by strep species. But like I said, there is a little bit of a difference, and erysipelas can be seen in little kids more commonly, and it's usually group A strep rather than the other streptococcal species. Versus cellulitis, which again is most commonly strep. It's staph cellulitis is not that common, does occur but isn't common, and dual infection is also fairly uncommon. So it's usually streps. Now, one of the things that you do early on in ED assessment when you're seeing someone with cellulitis is to try and determine whether they need to come into hospital or whether they can be suitable for outpatient treatment. Unfortunately, there's no clear guidelines or protocol or hard sort of signs that you can use to determine that. It is to a certain degree clinical judgment and experience, but obviously patients that are septic need to come into hospital. Also patients that are at increased risk of complications, whether that's because they're very frail or a poorly controlled diabetic or immunosuppressed, or those that are not really showing any form of improvement after 48 hours of a reasonable trial of a good dose of antibiotics. But remember, hospital in the home, so they don't, whilst they may need IV treatment, they don't necessarily need to come into hospital. And there are ways of getting around multiple daily dosings of antibiotics. So one common way that we do that is to give them some oral probenecid, which actually increases the half-life and the serum levels. It's often used with cefazolin, but you can use it with other beta-lactams as well. And so that enables them to reduce the frequency of their dosing down, which makes HIT logistically possible.
So it just gives them a mild renal impairment.
It doesn't give them renal impairment, but it inhibits the renal tubular transporter, so they're not excreting as much of their antibiotics, so they have increased serum levels. So it shouldn't actually give them renal toxicity, but it should just allow them to be dosed a little bit lower and have the same sort of efficacy as more frequent IV dosing. How long do you treat someone with cellulitis for? To a certain degree, how long's a piece of string? It's pretty individual, but generally the rule is until at least 2 days after the erythema is resolved. So that treatment obviously will vary, but in practice it's often 7 to 10 days total, and that's IV plus oral. The maximum you're probably looking at is about 2 weeks, and that would be in someone with a lot of risk factors who's slow to settle and who's maybe had an abscess or something that's been drained and had a more significant infection. So case 2, so 75-year-old lady, left leg cellulitis, she's febrile and tachycardic, she's got a pretty high CRP of 260, so first line treatment, you guys should know this off by heart. What do we give her? Yeah, but blood cultures first. So just a reminder, when they meet the sepsis criteria, it's good practice to be taking blood cultures. A reasonable percentage could be bacteremic, and that has implications depending on what the bacteremia is, of if you need to increase the duration of their treatment or look for other foci of infection as well. So that's important to do. But yes, Fluclox absolutely is the first line treatment in someone without previous allergies or other contraindications. So you're called to see this same person 36 hours later on the ward when you're on after hours, and the leg's looking a lot more angry, a lot redder, there's some blistering, but everything else has actually improved. So her fever and her tachycardia have settled, her obs are between the flags. So what do you do now?
Check the swabs.
Yeah? Anything else? Do you change her treatment? Do you worry? So those are the options that I've given. What do you guys think? We've got...
No change.
Yeah. So...
She's fever and tachy are kind of more important.
And that's the key thing.
Colour.
Yeah, so you're absolutely right. The blistering and that classical progression of the erythema looking worse is very commonly seen in streptococcal cellulitis and isn't an actual sign of treatment failure or any need to change or
Isn't the
broaden.
blistering made it staph?
So, no, blistering
Or
is characteristic of strep.
Cellulitis?
No, more common with strep. So that's local symptoms can worsen, but systemic symptoms improve. So sit tight. Don't worry about it too much unless they're actually deteriorating in other ways. So this lady, 82-year-old, cellulitis, thinks she had a reaction to penicillin 60 years ago, can't really recall what it was, thinks maybe it was a rash, but maybe it was nausea, but maybe it was something else, and she's not too sure. What do? The answer is not ring ID. So I'm sure you all do this very diligently, but further questioning and collateral history is really important. So she thinks she had a rash and it was maybe after a few days of an antibiotic as a child. So other things you can do, ring the GP if it's in hours. Appreciate that's difficult out of hours to do. Have a good look on EMR. The amount of times I'm told over the phone that we've got absolutely no information on what antibiotics this person has had in the past, and I log on 10 minutes later and find that they've had Augmentin 5 times, they've had cefuroxime last month. So don't be scared just because someone's written that they have an allergy. It's usually not the case. So this lady had multiple courses of Keflex. So yes, I appreciate you might not want to give a penicillin or a flucloxacillin in this lady if you really aren't sure, but it sounds like she doesn't cross-react to cephalosporins, so you're pretty okay to give the second line therapy when they can't have fluclox, which would be cefazolin. So next case, slightly younger chap, 59, diabetic, had a history of rash about 10 years ago after a course of amoxil, but describes it as skin peeling off and he needed admission. So what did he have? Yeah, so something along the lines of a Stevens-Johnson or a Dress syndrome. So you want to avoid beta-lactams. This is the kind of person that you don't want to risk it. They had a serious sounding reaction. So you'd go for a non-beta-lactam option. So you're looking at vancomycin or clindamycin. So penicillin allergy, you obviously don't want to use beta-lactams if they've got a good history of an IgE-mediated immediate reaction, so something like anaphylaxis or an anaphylactoid reaction, or a severe non-immediate, non-IgE-mediated reaction, so like a Dress syndrome or a Stevens-Johnson 10. You can occasionally desensitize these people if you really think that they should have a penicillin, but for most cases of a community-acquired cellulitis, it's not necessary. And we don't commonly desensitize for this indication. So the next slide's really important, and I think it's something that we don't do very well in hospital as a whole. And it's all of the adjunctive treatment that's so important for cellulitis, and often if these things are done in hospital, they're probably more contributory to why they got better versus why they didn't improve with the GP course of oral fluclox. And it's because when they get admitted, they actually elevate their legs and rest, as opposed to being at home and carrying on looking after their other family members and walking their dog. But addressing their diabetic control as well, addressing compression bandaging, identifying the risk factors that they may have had that might be modifiable, both helps treat their current cellulitis and helps reduce their chance of other episodes of cellulitis. And the tinea between the toes is a really big one. They may not have ever noticed, they may not look at their toes ever, and if they don't mention it to their GP, nor would their GP. So it's something that you can start them on some Lamisil ointment and reduce their chance of further cellulitis. So this one doesn't project as well, sorry, the writing's a bit small, but this lady, this is probably one of the most common scenarios that we get called from ID, and it's still a very simple ward-based scenario. A lady with cellulitis, she's been on a good dose of IV fluclox for the last 3 days. She's still febrile, things are not improving, she's still a bit tachycardic, so she's not the scenario where it just looks worse but she's better. She's actually not better, and she's a pretty complex lady, a lot of comorbidities. So what sorts of strategies do you think you guys can do?
Interrepeat the septic screen.
Yeah, definitely, especially if she's been in a few days, she could have something else. Anything else?
Check the sensitivities. And
Yeah. Of swabs and things, if she had ulcers. Anything else? We've got a lot to get through, so I won't dwell on it too much, but there's a whole host of things that you can do. most of which can be done before ID get involved. So this is in sort of no particular order, but if they're septic, then make sure they've had some blood cultures. If they haven't had any blood cultures, you should do some blood cultures. If they have, chase the results. And like you said, reconsider, could there be an additional thing at play now that they've been in hospital for more than 48 hours? Have they got an additional focus? If wounds or ulcers are present, swab them or chase swabs that were done in ED and see if you need to adjust therapy on the basis of that. Think about whether antibiotics are actually reaching the site. So they're having IV antibiotics, but they might have extreme lymphedema and just really not be getting very good tissue penetration of the antibiotics. Or in the case of diabetics with foot ulcers, they may need revascularizing because the antibiotics can only work if the blood supply is reaching the area that's affected. So that's something that can be done. Consider whether there's an abscess that actually needs drainage. Again, it's to do with antibiotic penetration. You're probably not going to achieve a cure if you're not getting the antibiotic into a big collection. It's going to need aspiration, essentially. And the same goes for an ulcer. You may want to do further imaging to exclude a deeper infection such as osteomyelitis, particularly if it's over, say, the tibia or a bony prominence where there's not a lot of soft tissue underneath. Consider MRSA. Staph cellulitis is still less common than strep, even in someone who's MRSA colonized. They're still probably got streptococcal cellulitis, but think about it, and you may want to add in vanc. And unfortunately, I can't give you a good guideline to say when you do it. It's a bit case by case, and you may need to run it past us. Think about also revisiting the history, especially if it's a very limited ED history because they didn't have time or they couldn't get a collateral. Could they be at risk of something unusual? Did someone miss the fact that they went swimming in the rock pool right before this happened, or they just went to Kenya last month, or anything like that? And think about whether they are immunosuppressed in any way. And if it's really rapidly progressing, then keep your wits about you, but think about necrotizing fasciitis. Could that have been missed? And is this something that you need to get on top of sooner rather than later? So those are just a few things. There's probably more to add to that list. Ring us if you need to, but a lot of those can be done without us as well. So community-acquired MRSA. In the Illawarra, there's probably around 20% of the population at MRSA colonized, so we have higher rates of colonization than a lot of other areas, which is why you'll see vancomycin coming up on a lot of our sepsis of unknown origin protocols, whereas in other places that you've worked it might not come up. That's because of our high prevalence of colonization. And there are different types. There's hospital strain of MRSA, which is more resistant. The community-acquired strain is usually less resistant, so you've got a few more options, such as clindamycin, Bactrim, ciprofloxacin. But it is being seen increasingly in patients admitted to the hospital, and it is associated with skin and soft tissue infections, but also necrotizing pneumonia, often following influenza or viral type illness. And the strain of MRSA often has a virulence factor called PVL, which you don't particularly need to know about, but that's just what makes it a bit nastier. And so known carriage, you'll find it in the alerts tab on the left-hand column of Power Chart. If they've been previously isolated, it will say over there. Contact sports, so places where they sort of sweat a lot and share changing rooms and share knee pads and whatever. Specific population groups that are at risk, so Aboriginal Torres Strait Islander, but also poor hygiene conditions in general, and the IVDU and HIV population have slightly higher carriage rates as well. So just a quick bit about Staph aureus decolonization. This isn't really specifically in the setting of cellulitis, but this is perhaps people that get recurrent boils and carbuncles and sort of skin infections. We do consider decolonizing them. It's not very successful, unfortunately, and it's quite a bit of work. So usually we just decolonize the patient. We don't always do their household contacts unless we failed a first attempt at decolonizing them, or the household contacts also have a history of the same. So you make sure that they've got no existing boils or active infection, and then once they're clear of that, There's a standard regime involving some mupirocin ointment and then a body wash, which you can buy over the counter, the Physohex. But the tricky bit is that they need to wash all their clothes and towels and bed sheets and things at a very high temperature, which most people don't do because it will ruin the clothes and bed sheets. And you're looking at around a 60% success rate if that regimen is followed absolutely perfectly, which I can guarantee you it won't be. And if you factor in treating multiple family members, then you're multiplying that probability and you're looking at pretty slim chances of decolonizing them. But if it's really troubling someone and they're in every other week getting boils and abscesses aspirated in ED, it's worth a shot. You might be lucky. So that was a bit of an aside. Okay, next one. We're whizzing through it. Sorry, am I going too fast? 74-year-old guy, diabetic, poorly controlled, day 2 of flu clocks. He's been in already another time this year. And he asks you, what can I do to stop getting this cellulitis? What do you tell him?
Control your diabetes.
Yeah, definitely.
Fix your tinea,
Yeah.
moisturize your face.
See, you guys have been listening to me. All of those things. But the big thing that came out in 2013, I think now, is the big NEJM article about penicillin prophylaxis. Does everybody know about the big NEJM article about penicillin prophylaxis? Excellent. So penicillin, our humble antibiotic that still works really, really well for most streps, is very effective at preventing recurrent cellulitis because cellulitis is mostly streptococcal. So this was a double-blind RCT, and there have been other RCTs that have shown the same. And essentially, they looked at penicillin or placebo for a year, looking at time to first recurrence, and they followed them for 3 years. And they found that the patients that were on penicillin, not only did it take a lot longer before they got a recurrence, but also they were less likely to have a recurrence. And the number needed to treat was only 5.
It's only
So
90 days better than the placebo.
yeah, but look, a lot fewer of them got a recurrence. And there was no significant difference in adverse effects. So it is effective, but they have to keep taking it. And so they need to have had 2 episodes in the last 3 years to qualify, and obviously not be penicillin allergic. But it's really well tolerated, and we have patients that we see in clinic that we put on prophylaxis and no more cellulitis.
Yeah.
Simultaneously, we do address their other risk factors, sure, but it is effective. You generally continue it until they have a breakthrough infection, and then...
But the control group also had the other factors addressed?
Yeah. So in this, they all had exactly the same other than the penicillin.
Is there concerns that if they do get an infection, they'll have resistant?
No, we just don't see that resistance mounting. The strep species have been treated with penicillin for as long as we've had antibiotics, and they're still pretty much all susceptible to penicillin. So, yeah, no real concerns. It won't obviously work for a Staph aureus or an MRSA cellulitis. They can still get it, but in most people it actually works pretty well. So it's definitely something to consider. You can refer them to ID clinic for this, but it's something that a GP could easily initiate as well. So diabetics, I'm not going to go into heaps of detail. There's quite a good diabetic foot protocol which you can get on the intranet, on the ID section of the website. So they are a bit of a special population, especially because they often have ulceration at play, and they need a sort of multidisciplinary combined approach. So Gabby, when she was on our team, single-handedly managed a lot of these patients along with the bosses, and knows that they're a bit of a handful. So they also get streptococcal cellulitis, as we've said, but they are also more at risk of having other gram-negative bugs and anaerobes because of the presence of ulceration being a factor, and they usually have peripheral vascular disease as well. So again, if they're septic or things are looking nasty in the sense of associated abscesses or possible osteomyelitis, it's good to not only swab the ulcer but also take some blood cultures. Swabs we do have to take with a pinch of salt because the ulcers have been open for months. They are going to be colonized with a lot of rubbish, but certain bugs, the presence of Staph aureus in a superficial swab is a pretty good indicator of Staph aureus being a pathogen deeper down in the bone. So there are good reasons to do a swab, and then we do pay attention to them. Key thing when you see them in ED is if they don't meet the sepsis criteria, don't start them on antibiotics. They've had the ulcer for 6 months. So yes, they've come into hospital and they're probably a bit worse, but nothing's going to happen to them in the next 24 hours, and they're being closely monitored. And the best thing we can do is get some good sampling if they've got osteomyelitis, and then we can target their treatment. We often don't have many opportunities to get a good representative sample, and often we're committing them to 6+ weeks of intravenous antibiotics. If we get it wrong, there's significant burden from that. So the things to do are to assess the likelihood of osteomyelitis under the ulcer, and if it probes to bone, it's by definition osteomyelitis, doesn't matter what anyone else tells you. And obviously it's further assessed based on imaging and in theatre. And to also assess the vascular supply by feeling the foot pulses, getting a good history, and assess the level of peripheral neuropathy from their diabetes. And as I said, it's a very combined approach. We regularly discuss with the vascular team, but the endocrinologists are involved to optimise their diabetic control. The podiatrists are involved, and also orthopaedics are sometimes involved if specialised procedures need to be done in theatre. So they're a bit of a separate category, but obviously they can present as a cellulitis, and unless you undo all of their bandages, you may not find the ulcer that's the culprit. And I appreciate it's sometimes really hard to get all their bandaging undone in ED, and the nurses get upset at you, so it's not always easy. So moving on to some a bit more interesting stuff. So this young lady has right arm cellulitis, and her cat bit her, sorry, didn't bite you. It bit her 2 days ago. It might bite you. So does anybody know some of the bugs? We'll talk a little bit about human bites as well. We've also had the same scenario of a drug user who's been bitten by a fellow human. It's actually surprisingly common. We do see this quite often. So does anybody know what some of the bugs are?
Strep mutans?
You can get all sorts. Yeah, it would be one of them. So I mean, it's mouth bugs predominantly. So human bites, you get all the oral bugs. Strep mutans will be like an oral type strep. So you can get strep species of a variety of types. You can get oral anaerobes. You can get Staph aureus, and you can get Eikenella, which is a gram-negative bug, but mouth bugs. Animal, also mouth bugs, but animal mouths. So does anybody know? Bartonella is more cat scratch. Pastorella is the big one. So Pastorella species, but also Staph aureus. Capnocytophaga from dogs. Strep species and anaerobes. So I don't expect you to remember this. Just remember that there can be weird bugs. So not just your usuals. And treatment, you've got to make sure that they've got some tetanus prophylaxis. If you're not sure if they've been vaccinated or if they've had doses but haven't had any boosters, you might need to dose them up again. And cleaning and debriding the area is important. And antibiotics pretty much for all of them, unless it's extremely low risk, so very small, not near tendons or joints. They present really quickly and they can have good follow-up and good debridement, which for most of them is not the case. So in practice, pretty much all of them get antibiotics. Cat bites have a higher incidence of deeper infection than dog bites. So don't get a cat.
If I needed any excuse to not be a cat lover.
And I mean, we know the kinds of bugs that might be at play, but we do like to get sampling to guide our treatment. So it's useful to get tissue samples when they go for debridement to send for a gram stain and culture and modify as required. If it's the hands or the face, that's high risk. So you might need to get hand surgeons involved or plastics, and consider delayed wound closure. But treatment is pretty simple. If it's all very early and simple and not severe, they can get away with some oral augmentin. But anything more than that, mild infection usually also treated orally, but if it's more severe, you'll find the guidelines saying tazocin, and you'll see tazocin written on ETG, but that's going to likely be revised in the next year or two. It was written before we had IV augmentin available in Australia. IV augmentin is more than adequate for these people. It's a great option. So you don't need to switch to tazocin. You don't really need pseudomonal cover in these. It's not a common pathogen with bites. So IV augmentin's fine. Usually you can get away with ceftriaxone and metronidazole as well, but augmentin probably has slightly better pastorella cover. So next case, 47-year-old guy. I think most of these are vaguely based on real people I've seen, but right foot cellulitis, just been to Hawaii, thinks he stepped on a sharp piece of coral. What bug is associated with coral cuts? You guys might know this. No? Vibrio is one that's associated with water, but coral is actually just group A strep. It's usually just group A strep, sometimes staph. So not as unusual as you might think. But group A strep can be nasty, so they can get a pretty bad cellulitis. Can be marine things. So waterborne injuries in general, you sort of need to divide it into the type of water. So this is where history is important and what they did and where they cut their foot and what they were doing. So salty water is characteristically Vibrio vulnificus, and Alginoliticus, another species of Vibrio, and other non-cholera Vibrios. And this other one called Schwannella, putrefaciens. So putrefies your fascia. Fresh water or brackish water, which is slightly salty water. I didn't know what brackish water was before I did ID. Is classically an Aeromonas type species that can also be seen if there's mud involved. And fish tanks, this is more for those who are going to pursue a career as a physician. It commonly comes up in the physician exams. Classical injury from people that work putting their hands into fish tanks or people that have pet fish is to get an ulcerated lesion that's usually caused by Mycobacterium marinum. So it requires prolonged treatment. Again, you don't have to remember any of these. Just remember that there are weird bugs and try and find out what kind of water they were exposed to, if you can. So the treatment can be tricky. There are some guidelines on ETG, but they're not comprehensive, and usually at this stage you get ID advice for these types of patients. So Aeromonas has a whole range of clinical spectrum, so it can be quite superficial, but it can also be really severe myositis and sepsis with metastatic complications elsewhere in the body. Often the patients affected by this have risk factors such as malignancy. I think liver disease also puts them at risk. If you suspect it, ciprofloxacin is one of the antibiotics that we use empirically until we've got culture results. And Vibrio species can be really, really awful. Sorry, Vibrio is the one that's seen in liver disease and cirrhotics. So that can be really life-threatening and fulminant, almost like a necrotizing fasciitis. So cirrhotics, people with iron overload, are particularly at risk. And they are sort of managed a lot like a neck vash. So they need a lot of incision and drainage, debridement. And antibiotic susceptibility is quite variable depending on the Vibrio species. So we generally go by culture results. So moving swiftly on, we're almost through all of them. So young lady, diabetic again, they're all diabetic, there's a theme here. Increasing swelling left eye, feeling feverish, looks a bit like this person in the picture. So what do we do with her? What do we think it is? Is it is it preceptal or postseptal?
You can't tell.
Exactly right. You can't tell. So she needs imaging, really. It's really hard to tell clinically. Clues to orbital would be actual pain with eye movements, reduced vision, or proptosis. If they get to the stage of proptosis, you're in massive trouble. And systemically unwell. So you can't really tell, and err on the side of caution with these people because it's their eye. You don't want to risk their sight. So preseptal cellulitis, so the periorbital, more superficial cellulitis, is your common staphs and streps. Especially if they've started off with a sty in their eye, or if they've had a bit of impetigo on their face or something, that's going to be more common. And it's just cellulitis around their eye. Haemophilus influenzae is something to think about in little kiddies that haven't been fully vaccinated against Haemophilus. And so they need slightly different treatment because Haemophilus often has a beta-lactamase and it needs augmentin to treat it. So Fluclox, Keflex for the standard ones, or augmentin if you're thinking about Haemophilus in little kiddies. But if they're severe or you're not sure, treat them as a septic patient if they're meeting sepsis criteria. Treat them as an orbital until you've proven otherwise. Take some cultures and get some imaging. And yeah, orbital cellulitis is really dangerous, and we've only had one case. I've only seen one case. So
that picture again?
it's pretty nasty. So yeah, it can be really, really awful. So it's usually can sort of spread from infection in the paranasal sinuses, but it can be also from orbital trauma. And they need 4-hourly eye observations and urgent surgical drainage. They can get intracranial spread and complications. It's really very dangerous. Similar kinds of bugs causing it. Sometimes you can get anaerobes at play if it's spread from, for example, a dental abscess. So they get treatment quite broadly with ceftriaxone and flucloxacillin. So you want to cover the staph with the fluclox, but the ceftriaxone will give you some Haemophilus cover. Most of the oral anaerobes are quite susceptible to penicillins and ceftriaxone, so you probably get away without metronidazole, but sometimes that does need to be added in. Ring us, and then we de-escalate or change depending on culture susceptibilities. If they're immunosuppressed or diabetic, just be wary that severe fungal infection caused by mucormycosis can look a little similar in the early stages. So they can also get a similar appearance, but they often have almost dehiscence of the roof of the mouth and basically invasive fungal infection. It's pretty rare. So next one, am I scaring you yet? Oh, this is a real case, and I've got a real photo of this patient with their consent. So 53-year-old guy came in, I don't know if any of you would have maybe seen this person, pain in his right ankle, thought he heard it pop when he was moving some boxes in his office the day before, came to ED in a peripheral site, had a bit of mild swelling of the ankle, but good range of movement, not really focally tender. Obs were stable, he was afebrile, he was treated appropriately and discharged home with rice and treated as a strain essentially. Came back the same day though, needing his wife's endone, pain's not very well controlled, but examination was essentially unchanged. Low grade temperature now, 37.8. They did an x-ray just to make sure, didn't have a fracture. Sent him home with some better analgesia so he stopped pinching his wife's endone and hope for the best. And then he came back 24 hours later, really bad pain. Now he's got erythema tracking up his right leg, it's swollen, he's febrile, he's rigoring, he's hypotensive. What does he have? Not septic arthritis.
Tendinitis?
No. What's happening? He's getting worse fairly quickly.
Necrotizing fasciitis.
There we go. So characteristics, that sensation of feeling a pop or a crack is oddly common in patients with necrotizing fasciitis. They just commonly report it. It's not, I don't know what that's from, but it just seems to be coming up in a lot of their histories. No, it's just probably a site of weakness in a susceptible limb. No, that's not what that. It's just it precedes it by quite a while, so it just seems to be anecdotally what they often describe. So
would you not think it was
what were his risk factors?
Yeah, like did he have
None.
a wound on his foot or something?
You don't have to have risk factors for it.
So what would make you think it was not a septic arthritis, the spreading erythema?
The
probably?
spreading, yeah. He may have an intercurrent, or he did have an intercurrent septic arthritis, but so necrotizing fasciitis is really bad news, and the mainstay of treatment is debridement, not antibiotics, but antibiotics are adjunctive. There are different types, so the monomicrobial type caused by one bug is usually either group A strep or Clostridium perfringens, and and that causes the classical gas gangrene. But other bugs can do it as well. So the Vibrio that we talked about with waterborne injuries can cause it. Staph aureus can do it. Aeromonas can do it as well. So there are a few bugs. It can also be polymicrobial, so multiple bugs, also known as a sort of synergistic gangrene, and it's mixed aerobes and anaerobes. Fournier's is a subset of that, affecting the genitalia. So clues are constant severe pain, often disproportionate to what you're seeing on examination. So he had that. The second time he came back, he was in a lot of pain, but the examination was unremarkable, really. They can be systemically toxic, but depends on at what time point you catch them, so they may not have those features yet, but the infection does spread rapidly. They can get bulla formation and necrosis and bruising. The subcutaneous tissue can be very hard and wooden, or very exquisitely painful to touch. And they can get gas in the soft tissues, but they don't always have to have gas in the soft tissues, and you can't rely on that as an excluding factor. So if you CT them and there's no gas, that doesn't mean they don't have necrotizing fasciitis. It could still be on the cards. So just be a bit wary of that, because you often see the surgical teams coming down and saying CT, no gas, not neck fash. It still can be, absolutely still can be. You need to go in and debride and see it, and that's how they diagnose it. So this is just a table. I'm not going to read all of it out, but although you can absolutely have risk factors, particularly for that synergistic polymicrobial type of neck fash, often seen in the diabetic population or people with surgical wounds or a lot of chronic diseases. But streptococcal, so group A strep, usually we're talking about fit and healthy individuals with no specific risk factors. They may have had a skin lesion that's a portal of entry, but often the theory is that we carry strep in our throats. Some people are unlucky and carry a particularly virulent strain of group A strep in their throats, and anything, an intercurrent virus, can make it just cross over into the bloodstream, or it can just do that by chance. And it can go and lodge itself, often in somewhere where they've either strained it or twisted it or something like that guy who sort of probably twisted his ankle a bit when he was moving his boxes or whatever he was doing. So it can just happen, and it's really dangerous. The Clostridium is more often seen in, again, sort of open fractures or ischemic limbs for other reasons. With the polymicrobial type, you really need to have broad cover. So you're looking at meropenem and vanc. All of them generally get some clindamycin as well. I've actually not put it on there, but most of them get clindamycin, and the clindamycin is for toxin effect. So especially with strep and Clostridium, they're the toxin producers, and you want to have something to inactivate the toxin that's causing a lot of the tissue lysis and damage. So it's not there as an antibiotic, it's there actually as an antitoxin, and you give it for the first 72 hours only. If they can't have clindamycin, you can sometimes use linezolid as well, but you wouldn't be doing that without speaking to us. Both the Clostridium and the strep are susceptible to benzyl penicillin. So it's not complex treatment, but the antibiotics are just adjunctive to keep them alive long enough to go to theatre to have all of their debridements, and they commonly need more than one debridement. So that at the bottom there is that guy's leg that was amputated to save his life. So he didn't do well. He went to theatre, he had debridement, he had fasciotomies, he had all the right antibiotics, he was in ICU on maximum inotropes, multi-organ failure, not winning, and the decision was made. It was either his leg or his life, and they amputated his leg, and he did very well, and he's fine now. He's had rehab, and he's good, but he lost his leg for that, and he was only 53. So, yeah, and they didn't know which sample to send to the lab, so they sent the whole leg. So that was a fun morning. And so they grew group A strep from the tissue. He actually didn't grow it from blood cultures, interestingly. The top picture is of a lady who also had group A strep neck fash, who ended up in ICU, and she also had an empyema as well, with E. coli, so she was a bit complex. And she was very young, 37. She did have some comorbidity. She had some sort of protein losing enteropathy or something, but she wasn't your conventional risk factor, and she was just found collapsed at home, semi-conscious by her kids, and had this rapidly progressive cellulitis. And she survived, but she was in ICU for a really long time. Well, I think she survived. So that's a bit of a massive whiz through cellulitis and skin and soft tissue infections. I know it was pretty fast, but I'll go through some take-home messages. That's just a little summary of some of the bugs. So key things to take away from this, if anything. Think again if you think it's bilateral cellulitis. I don't want to hear about it. Don't call me about it. It's usually strep, not staph. So that whole worry about if and when to add vanc is often a little premature. Most of these people do fine, but the adjunctive treatments are really important, and they are hard to get done within the permutations of nursing staff availability and things. But all of those elevation and compression and diabetic control and all that is really important. Penicillin prophylaxis is an option for the frequent flyers that are coming in recurrently with cellulitis. And as a junior, I guess your priorities when you first see these patients are sort of to try and even mentally triage them. You know, are they septic or are they not septic? Do they have neck fash? Is it rapidly progressing? Can they be an inpatient? Should they be an outpatient? Do they have something weird in their history that makes me want to talk to ID early? Were they just out swimming? Try and get a good allergy history, and that might just be going through the last 4 years of their EMR notes and seeing if they had Keflex or Kefuroxime for a respiratory tract infection or something, but it's really helpful to know. And bloods and swabs and cultures are obviously part of the routine workup. And ETG's got a really good section on skin and soft tissue infections. I think it's all very underutilized. Read ETG, it's really good. And it's very evidence-based. And read the small print, because it often explains all of this stuff, and that would save me a lot of calls. And that's about it. So, any questions, guys? I think I finished just on time. So, sorry it was fast. All riveted.
This is just an interest question, but the gentleman whose pain was disproportionate,
Yeah.
like reflecting back, should things have been done differently that particular admission?
Probably not, because I think it would have been hard for the doctors, and he was in a peripheral hospital. He didn't have, they often don't have risk factors. I don't think they really did anything wrong, other than when he came back needing endone. Perhaps my view is skewed because I'm more inclined to suspect these things. I'd be a bit worried for someone needing a lot of endone for a simple strain.
Yeah.
But that's just maybe my own bias. A lot of these patients, they might have a positive blood culture, and as soon as the blood culture flags, obviously I've got additional information, but I look through the history and I think it's classical group A strep neck fash. They just have that history of sort of disproportionate pain with limited clinical findings. I had another lady who was very similar, who I've not presented on here, and that exact scenario occurred. Positive blood culture, the lab rang me, it looks like strep in the blood cultures. They don't know which strep at that point. And I looked at ED, she'd been sent home, but she came in with horrific left thigh pain with a very mild patch of erythema. They thought it was prodromal shingles and gave her steroids and antivirals, probably the two things that would have done her least benefit, and sent her home. And then nobody could find her for the next 2 days, and we thought she died from a rapidly progressing neck fash. Luckily she hadn't, and through much chasing I got hold of her GP. We brought her straight to ED, and she ended up within about half an hour in ICU on inotropes and went straight to theatre and had about 4 debridements for her neck fash that was progressing in the community. And so, not to terrify anyone, but just have that index of suspicion.
Every sprain in ED now, I'm going to call you.
It's really disproportionate. I know that people have different pain thresholds, but if someone is needing huge amounts of analgesia, and it's it's odd. It should ring alarm bells.
But you're saying that most of those cases would flag positive cultures, or some of them wouldn't?
The guy that lost his leg never actually grew it in blood cultures, but that may have been due to the timing of his blood cultures versus antibiotics. If they get, most of them are bacteremic, at least for a short period, and if you manage to get some cultures prior to antibiotics, you should be able to grow it. Yeah, don't worry too much about it, but just be suspicious. Just have that index.
I think I was totally always thinking you needed to have some sort of external injury or something.
Yeah, not
Oblivious
always.
to the fact it could be
Not always.
seeded.
They may have an injury, but yeah, they don't have to. We certainly see them that don't. So we went through a spate of it last year. There was a big outbreak. I'm doing a project on it at the moment, but yeah, it's still to be determined if there's any correlation with what happened last year. We wondered whether the flu outbreak had something to do with it, and whether people were getting into current flu and causing them, if they were carrying the group A strep in their throats, causing it to sort of cross over the inflamed mucosa into the bloodstream and then seed. Because we just had a dramatic increase in group A strep infections in general last year. So
Have you found anything yet?
I've not started the project yet. So the plan is to do some whole genome sequencing on the isolates of group A strep and see if they've got any common virulence factors and to see what was going on there. So watch the space. Yeah. All right, guys. I think you're all free to go. I've got to record a little summary, so I'll see what they tell me about. Thanks for coming.
Thank you.
And, yeah.
Are you actually gonna do something? Or do you want me to do the recording? The summary doesn't really, I don't think it does anything. Nobody watched it, so I would be more than happy for you to just sign off.
I'm
Mind if I just-
happy. Yeah, we can sign off.
Alright. I mean,
The summary was only going to be the last slide anyway.
Yes,
so
but I thought.
it's
I
not
think you've already
very,
summarised it. That's
yeah.
cool.